Hi guys, in this video I'm going to talk about ST elevation MI, the diagnostic criteria, management perspective and the complications. But before that we'll have a look at why do these patients die. In fact, a large number of these patients might die on the way to the hospital in the ambulance on our arrival into the hospital. So especially if he talks about out of hospital mortality, then the leading cause of death should be answered by you as tachyarrhythmias. And that would either be a ventricular fibrillation or it could be a pulseless ventricular tachycardia, which would result in a hemodynamic collapse. But if a person was admitted to the hospital, he was subjected to a primary percutaneous coronary intervention within 90 minutes of arrival to the hospital, or maybe was subjected to thrombolysis and still he expired. Well, what really went wrong here? Then the casual word that I can use at the moment to describe in-hospital mortality would be a pump failure or a development of cardiogenic shock, for which we will have to use inotropic agents and we might even be using intra-aortic balloon pump. But still, because of decreased cardiac output, there would be a decreased coronary blood flow, there would be decreased blood supply to the brain, decreased blood supply to the kidney, vital organs can shut down and the person can ultimately expire. So let's look at pathophysiology behind development of ST elevation myocardial infarction. Though nowadays incidence wise, just for your information sake, this is what Harrison is saying, that the prevalence of non-ST elevation MI is more than the prevalence of ST elevation MI per se. Why that is happening, there is no explanation for it, but I can say that in previous times we used to read that the incidence was almost equal, and in fact in some books it was mentioned ST elevation MI is more common, but current edition of the textbook mentions prevalence of ST elevation MI being relatively more common. Now, once we are going to talk about the treatment part, we need to understand the pathophysiology behind it, because platelets play an important role in this case, and there is a development of a fibrin-rich thrombus as well, which is why fibrinolysis is successful. So from the pathophysiology perspective, two statements that I would like to make it that one, we are having a big clot that is causing occlusion of the coronary artery. It could be like left anterior descending artery for anterior wall MI or the right coronary artery for inferior wall MI. So what we are having is a thrombotic occlusion of a culprit artery per se. But the bottom line is that once this artery gets occluded, how is it different from a ST elevation MI? Then the main fundamental difference between a ST and a non-ST elevation MI is that the thrombus that forms in this case would be a fibrin-rich clot, which explains the fact that why fibrinolysis will be successful, whereas the non-ST elevation MI, this would be rather a platelet-rich clot and fibrinolysis would not be successful. When I describe this, the usual query that I get from most of the doctors is that even in chronic stable angina, please don't draw it, just listen to me. In chronic stable angina also, you could be having a 80, 90 or 100% obstruction occurring in coronary artery. Yes, 100% obstruction in coronary artery in chronic stable angina, but still people do not die. Like here, you are giving us a bad prognosis, patient is dying on the way to the hospital. So suppose a person is having a 80, 90 or maybe a 99% blockage, still is not dying. Why? Because in chronic stable angina, the lesion is slowly developing. Because it develops very slowly, it gives time for the collaterals to develop, and therefore I can say that on a comparative basis, chronic stable angina would always be having is a relatively a better prognosis because the collaterals will do their job. And even if this person is having 100% physical obstruction by a atherosclerotic plaque, I never used the word thrombus here, I said atherosclerotic plaque is causing a complete luminal obstruction, still the collaterals which I have shown at the movement would be doing their job, and they would rather be preventing development of death or tachyarrhythmias in a person. Or I would say on a comparative basis, the possibility of development of tachyarrhythmias would be less because there would be a rich collateral network. But in patients who are suffering from ST elevation MI, we have first a plaque fissure, because every time blood goes through a coronary artery at high pressure, the atherosclerotic plaque can tear up. This will cause collagen to be exposed. The moment the collagen is exposed, the platelets will jump onto the opportunity, and then we have is an unfortunate scenario of a fibrin-rich clot developing in the coronary artery of the patient. I can say that even if a person is relatively young and he is using cocaine, that cocaine can not only cause a severe vasoconstriction, but even if a person is having minimal atherosclerotic plaque formation, because it's causing extreme vasoconstriction, this plaque can rupture, and that can explain development of MI in relatively younger individuals who did not have the classical atherosclerotic risk factors per se. Apart from this, I can say any hypercoagulable state will increase the chances of a clot formation. By hypercoagulable state here, I do not mean a pregnancy. By hypercoagulable state here, I mean conditions like factor V laden mutation or protein C deficiency or protein S deficiency, where the chances of development of thrombus formation would be relatively higher. And more importantly, once this event happens, the medical care has to be prompt. The delay in institution of medical treatment in these patients will explain why as much as 50% of these patients, if whatever is the percentage of deaths, the chances of death in a person will vary dependent on the medical care available in a particular city or in a particular vicinity of the residence of a person. Because let me say, let's take up example of Delhi. You have so many cardiology hospitals. The chances of a person reaching the hospital will be relatively higher and he would be saved. But let's take up a patient who's on the periphery of a small village in Haryana or maybe in a small town in Rajasthan. The chances of him reaching a PCI equipped center would be relatively lesser, because there would be obviously a delay in reaching the hospital, and therefore the chances of mortality can be relatively higher. But whatever death that will occur, 50% of them can occur outside the hospital due to development of tachyarrhythmias. So now on the basis of this pathophysiology and how is it different from chronic stable angina, let us focus on the clinical features that we'll be encountering in any patient who's having a ST elevation MI. And at the moment, I have not seen the ECG of the patient. I have this 60-year-old guy. Let me say he's a retired banker. He's a senior manager, was a senior manager in a big bank, and now he's retired. Though all his life he has been a smoker. He was also a diabetic who was not very regular with his medication or could be having a pre-diabetic range at the moment. He was also hypertensive and was non-compliant for his medication. This gentleman at the moment is experiencing extreme crushing. I mean, most patients will say, sir, the pain was so bad that I thought that I'll never live. I mean, when he's telling you this in a retrospective, when you have treated him by PC or by thrombolysis, he said, sir, the chest pain was so bad that I thought I'm not going to survive. And in some cases, the pain can be so intense that patient can develop vasovagal syncope and can expire as well. So crushing chest pain at rest. And most patients would either put their whole hand in the middle of the chest or a fist on the chest to describe this extreme pain. So the technical term that I've said earlier also, and I'm repeating at the moment, would be Levine sign to describe this oppressive chest pain experienced by these patients. In a large number of cases, this pain might initially be radiating to the epigastrium, as a result of which the person might think that he's having gastritis or he's having indigestion, or like in India, people call it a gas problem. So there is a possibility that even in a multiple choice question, he might begin by describing a 60-70-year-old man presenting with epigastric discomfort, and then he feels heaviness in the chest also. So he might not be using these classical terms like a crushing chest pain, but it might begin with a epigastric discomfort. In any person who's having this epigastric discomfort, you give antacids, and if you do not get relief within a couple of minutes, presume that this is myocardial infarction. In some patients, apart from epigastrium, the pain can radiate into the arm as well. In fact, the pain can radiate even up to the root of the tooth or up to the angle of the jaw. So the extension, or I would say the radiation of pain when it comes to myocardial infarction is fairly extensive, unlike in pericarditis, where I will say that the pain radiates to the shoulder. And mostly patients of pericarditis, they would still be relatively better up on sitting position. But in these patients, when you examine the patient, you will find a person who's literally trying to toss and turn in the bed. He's trying to change his position, trying to ease off the pain. The pain is so intense, he thinks if I change my position, maybe if I lie prone or if I try to lie laterally, he will try by changing his position by himself, thinking that I will get a relief, which would not happen in this case. And there would be no relief of pain even on rest, unlike in chronic stable angina. Suppose he was previously having chronic stable angina, maybe a 80%, 90% blockage in two of his arteries, and in one artery it was only 50% blockage. But that atherosclerotic plaque, which was causing 50% obstruction, today that developed a plaque fissure. And then the platelet jumped in and there was a fibrin-rich thrombus. So it's not about how much more amount of atherosclerosis that you're having. It's not about whether you have a 80 or a 90% obstruction or, atherosclerotic plaque fissure can occur in any atherosclerotic a percentage of obstruction. It doesn't matter. It could be an artery that is 90% occluded, that could be having a plaque fissure. It could be artery that is 50% occluded, it could be having a plaque fissure. It is just incidental at that point of time that this happened. And the person will say that earlier, like this guy of chronic stable angina, he said earlier I used to have relief of pain on rest or on taking nitroglycerin. But in most of these patients, you will have to, ultimately use morphine, or if morphine is not available, like in government hospitals, you might even have to use beta blockers in the patient to decrease the heart rate and then decrease the oxygen consumption of the heart, and the severity of the chest pain in the person would become relatively lesser. At this point of time, I just want to also remind you the fact that chest pain may not occur in diabetic patients, especially in patients who are having diabetic neuropathy. Patients of type 2 diabetes, non-compliant ones, once they develop the commonest, in fact, that's itself a MCQ. Commonest complication of type 2 diabetes is its diabetic neuropathy, and these patients could be having is a development of a silent myocardial infarction where the chest pain may not be experienced by an individual as well. This is the usual scenario that would be contributing to the presentation of the patient, though in some cases it is a possibility that this particular gentleman, he started exercising. He recently joined a gym. Like most Indians have never worked out in their life because they're always working and they're always after money. But once they go into post-retirement, you will notice people have more time at their disposal and more income at their disposal to join a gym. Now, a person who's not sensitized to working out in a gym, if he starts doing a vigorous exercise, then this vigorous exercise again can contribute to a atherosclerotic plaque tear, and that could result in a clot formation and a thrombotic occlusion of the coronary artery. And this is what we have seen. Like if I take a comedian's name, Johnny Lever sir, he was in it, I think he was in late 40s, early 50s, and he was working out in a gym in Delhi, and he collapsed. And similarly, there have been multiple instances where I would say celebrities, or at least television celebrities, this guy who's famous for working in a particular television serial, he walks into a gym, he's fine, and then he's doing bench press and he dies during that workout. And your relatives will be asking, what's going on? Why are so many young people dying of heart attack? That's actually a myocardial infarction, because vigorous exercise, the coronary blood flow is increased, the person is working out harder, and that could cause a tear in the atherosclerotic plaque. Instead of vigorous exercise, it might be emotional stress as well, or it could be a combination of the two. Like this guy was working out hard and he had a phone call, and there was some bad news. Maybe the stock market crashed and this guy lost all his earnings, all the money that he had earned in his life, he lost in a stock market crash. So it could even be a scenario of a medical illness, like a person suffered from severe COVID. We did have instances like this, that people recovered from severe COVID, and while they were in the recovery phase, they suffered from MI, because COVID itself is a hypercoagulable state. Or I can say, with respect to any prolonged surgery, a person could be having is a development of myocardial infarction. So it is not a necessity that they'll always give you a description of a person who's sitting on the dining table at 8 a.m. in the morning and is having an episode of myocardial infarction. Why MI usually occurs in early morning hours? You know that vasoconstriction is more in the body in the morning hours. So therefore, most of the attacks of MI, and mostly stroke and MI, occurs in morning hours. Why that happens is because I just mentioned, and you guys are anyway familiar with, that vasoconstriction is more in the body in the morning hours per se. So this is the usual presentation, but he might give you a person working out hard in a gym, or a person suffering from emotional distress due to a stock market crash. So any of these informations can be given in a question to describe the initial presentation of a man who's suffering from a myocardial infarction. And along with this, other symptoms would also develop, because if this is the anterobal MI, then gradually the pulmonary edema will start developing in a patient. So shortness of breath will be experienced by an individual. If he wants to go to the bathroom, he will say that I was feeling short of breath. So NYHA grade 3, that was a neat and NESET question as well. A person experiences breathlessness on even going to the bathroom, is an NYHA grade for dyspnea would be grade 3. Or he might just write the word DOE, that is dyspnea on exertion, in the patient. In some patients, if there is a severe cardiogenic shock developing, or if I say the left ventricular function is grossly deteriorated, there might even be loss of consciousness, though I've already explained to you that the reason for developmental loss of consciousness could also be vasovagal syncope in the patient. The bottom line at this point, or I would say the minimum information that I want you to remember, is that every time they give you a scenario of a person of chest pain on, I would say this person has previously experienced chest pain episodes on exercise, but is currently having chest pain at rest. And along with that, he's also having extreme profound sweating, because you see every time there would be severe pain present, there would be a lot of sympathomimetic stimulation happening. So there would be a lot of diaphoresis occurring in a person. Generally, I would say if you are educating non-medicos regarding presentation of MI, what you should tell these non-medicos, because they're not going to understand pulmonary edema component and shortness of breath aspects as well as you guys. So if you have to explain to a non-medical person what does heart attack actually cause, so it causes severe chest pain on rest that does not get relieved on change of position, or even on taking routine medications like nitrates, even if they're available at home. And this would be associated with concomitant sweating. If this is persisting for more than 30 minutes, try to make a dash to the hospital ASAP as early as possible, because this would be beyond the control of any physician or any medical person to handle at home. Now let us look at the examination findings that you are bound to get in this extremely profusely sweating individual who's very anxious. The heart rate would be increased, BP would be increased because of the sympathomimetic stimulation component. But there is a possibility that he might give you a scenario of an inferior MI. Obviously, you need to look at ECG to confirm an inferior MI, but because in inferior MI, vagus nerve gets involved. You see, vagus nerve in the heart is in the SA node, AV node, and in the wall of the right ventricle, and inferior MI involves the wall of the right ventricle. So in the vital situation, he might mention a bradycardia, for which you will have to give atropine. You don't use atropine in routine cases of MI, but in inferior MI, because of the bradycardia component, you'll be forced to use atropine. There would also be a hypotension, for which you might have to give IV fluids to maintain a systolic blood pressure of about 90/60. You do not use IV fluids in any other type of MI, but you use IV fluids in inferior wall myocardial infarction. And in these patients, even the JVP component would be elevated. This is again because the right ventricle of the patient is getting involved. Now, when you try to localize the apex beat, normally when you try to localize the apex impulse, it would be 2 centimeter medial to the midclavicular line in the 5th intercostal space. In majority of cases of myocardial infarction, because the heart will be relatively silent, I can say. So the textbook will say that the apex impulse will be relatively difficult to localize. This is because, as I said, it's a stunned myocardium, it's a damaged heart, because of which the apex impulse is difficult to localize at the moment. One bad, I would say, or bad news you would be having for your patient is auscultatory finding of pericardial friction rub. Pericardial friction rub basically tells you the fact that there is a transmural. Imagine the infarction is so extensive that it is not only causing involvement of the subendocardium or endocardium or myocardium, but it is even causing involvement of the pericardium. I mean, a full thickness infarction is required. I said if it's subendocardial damage or it's endocardial damage or myocardial damage, okay, I mean that's fairly extensive. But if it's a full thickness involvement that involves even the pericardium, I mean that will cause a pericardial friction rub. So from a doctor's perspective, pericardial friction rub, if heard in a MI patient, is bad news, because it is suggestive of the fact, and I mean you don't need to note it down, it's just for your information, that this is suggestive of the fact that the person has had a full thickness infarction. He's had a transmural myocardial infarction, and usually in transmural myocardial infarction, full thickness infarction, more is the muscle necrosis, you would start getting deep Q waves in the patient, which I'll be repeating subsequently the ECG findings of MI. But one very characteristic ECG finding of MI that persists for whole life. I mean, even if you treat the patient, the deep Q waves are never ever going to go back. And how do you know clinically that is trying to tell you about a transmural myocardial infarction? That's a presentation of a pericardial friction rub in a patient. Then over and above this, he might even talk about auscultatory finding of third and fourth heart sound in the patient. Why I am saying third heart sound is mainly because of the fact that there could be a left ventricular failure. Every time you have a heart failure, third heart sound would come up. And now, because this is a damaged heart, the atria will have to work against a resistance, and therefore fourth heart sound can be present in the patient. Another auscultatory finding that may or may not be given is that for second heart sound, he might say narrow split. I've explained in the topic of heart sounds that every time you have a narrow split second heart sound, it means that the left ventricle is getting involved or left ventricle is failing. If it's a wide split second heart sound, it means the right ventricle is getting involved. So this information of S2 narrow split may or may not be given, or in the early part of the presentation, you may not have had a full developed left ventricular failure. Now, in some cases, he might even mention regarding a murmur. So it's important that you need to remember what is the murmur that could be present in these patients. So either it will be a mid or it will be a late systolic murmur. And the reason for this mid or a late systolic murmur that would be developing in the patient could be acute mitral regurgitation. Now, before we go into the ECG findings in this particular case, let us just focus on the couple of differential diagnoses of acute chest pain that you must consider in this particular case. And this could be asked to you in your routine exams, which are usually clinically oriented nowadays. There are two A's which must be considered and should be answered. One is obviously acute pericarditis, which can be differentiated from that of MI, one on the basis of the radiation of the pain and second on the basis of ECG finding, because in MI, the ST elevation that would develop is convex upwards, but in pericarditis, the ST elevation would be concave in an upward direction. Another A which is to be remembered is aortic dissection. The highlight of aortic dissection would be that the pain would be relating mainly to the interscapular area, and you can be doing a CT chest or a CT angiography to demonstrate whether it's a type A or a type B aortic dissection, and you would be getting is a classical tennis ball appearance. The next important differential for acute chest pain that must be considered is pulmonary embolism. Every time you have a post-operative patient and he's having chest pain, especially if he says post-operative hip joint surgery or a post-operative knee replacement surgery, patient is experiencing chest pain because these chaps after a major joint replacement surgery could have had a deep vein thrombosis, and then the thrombus could have traveled retrogradely towards the heart and then could have contributed to pulmonary embolism in a patient. Much more lower down in the list would be costochondritis, which is called as Tietze syndrome, where there would be tenderness at the costochondral junctions in the patient. And if you ruled these out, the important dangerous ones, then GI disorders must be considered. I've kept GI disorders at the bottom because the more dangerous conditions should be ruled out. So some of the important differentials of acute chest pain that you must consider. Obviously, I have not at this point of time incorporated components of unstable angina or non-ST elevation MI because they've already been discussed in the earlier part of this video series per se. So they have not been incorporated here, but that is the usual thought process when you are dealing with a case of a myocardial infarction. Coming to the workup of the patient, the first investigation that will be done is a ECG. And well, you would have guessed it right. If I ask you what's the earliest ECG finding in a MI, then do not answer ST elevation. The earliest ECG finding in a myocardial infarction would be an increase in the amplitude of the T wave. And therefore, in your exam, if he says what's the first ECG finding in MI, your answer would be given as hyperacute T waves. Do not confuse this with tall tented T waves. That's a classical finding that we encounter in a patient who's having hyperkalemia. So there is a possibility that in multiple choice question, he might write even hyperacute T wave as well as it might be written simultaneously tall tented T waves. As I said, tall tented T waves are a ECG finding of hyperkalemia. So the moment there is a thrombus in the coronary artery, the amplitude of the T waves would increase. The normal vertical height of the T wave, you are familiar and I've discussed this earlier also, I'm repeating it once again. The vertical height of the T wave would be less than 5 millimeter as far as the limb lead are concerned. The vertical height would be less than 10 millimeter when it comes to the chest leads. And once the vertical height goes beyond this limit, then we are talking about a hyperacute T wave. Along with this, by the time the patient reaches the hospital, a large number of cases would be having another ECG finding of myocardial ischemia that would be a development of T wave inversion. So I repeat my statement, not all cases would be having that classical ST elevation, though if it is present, the ST elevation would look the way I am currently sketching before you. You will notice that when the R wave is going down, that is when you will be getting a convexity, and concomitant with that I have shown is a T wave inversion as well. Remember, in pericarditis, you will always be having is a ST elevation that is concave in an upward direction, but in myocardial infarction, this would be convex in an upward direction, and the terms that the examiner will be using to describe this ST elevation, which is convex upwards, would be 1 Pardee sign, or this convexity that I've shown can also be written as tombstone pattern. Well, the person is going to go towards God. So that is why, that's one way to remember ST elevation with the convexity upwards, and this would be associated with the T wave inversion. In fact, they can even quiz you or ask you that what should be the magnitude of this ST segment elevation. And why that's important for you to know is because when you will thrombolize the patient, you will notice that after thrombolizing, the ST elevation will start coming back to normal. But before that, you should be knowing that ST elevation more than how much is the cutoff that you need to use for institution of reperfusion therapy in a person. So remember these values of 2 millimeter or more. For female patients is actually 1.5 millimeter. For a male it is 2 millimeter, female is 1.5, though I'm describing 2 millimeter here at the moment. If you are able to demonstrate a ST elevation of more than 2 millimeter in at least 2 contiguous precordial leads, those contiguous precordial leads could be like V3, V4, or it could be, that's for anterior wall MI. If it's V5, V6, for a lateral wall MI, for septal, it could be V1, V2. So if you are able to demonstrate in the precordial leads, at least 2 of them, though it could be in more of them as well. For example, let me say I am having ST elevation from V1 to V6. That's a presentation of extensive anterior wall myocardial infarction. If it's present only in V5, V6, I'll say lateral wall myocardial infarction. If it is from V1 to V4, anterior wall MI. If it is V1, V2 alone, it would be a septal myocardial infarction. But I need to demonstrate at least in 2 contiguous precordial leads, ST elevation of more than 2 millimeter to say that this is a myocardial infarction. And the cutoff to be answered for limb lead criteria would be more than 1 millimeter. So if it is gonna be, I mean, you could be having his combinations as well, but the bottom line is, in the limb lead, the cutoff to be answered is 1 millimeter. For the chest lead, the cutoff to be answered is 2 millimeters. And again, it would be contiguous adjacent limb leads, like I have described for inferior wall MI in my discussion earlier, that lead number 2, lead number 3, and lead number AVF help in identification of inferior wall myocardial infarction. So these are a couple of findings that you need to remember, and this would be associated with a finding that's never ever going to go back. I mean, when you treat a person, ST elevation will gradually start coming back to normal. Like for example, on admission, the value was 4 millimeter. Once you start treating the patient, it will decrease to 3, it will decrease to 2. So your person is showing a response to your treatment. But one ECG finding which will persist for whole life of the patient is deep Q waves. In fact, the textbook says, Harrison says this statement that I'm making before you, that deep Q waves that develop in a patient of MI are directly proportional. I mean, the depth of these Q waves is directly proportional to the volume of tissue death, or the volume of tissue cell death that is happening in the heart of this patient. So I would say in a person having a transmural myocardial infarction or a full thickness infarction, the deep Q waves would be present. It usually takes about 1 hour for these ECG findings to appear, and they persist for whole life of the patient, because of which there has been question in the exam in the previous years that which of the following ECG findings is suggestive of a old myocardial infarction, or which ECG finding is suggestive of a previous myocardial infarction. Like this chap, he had a MI episode while he was admitted with us in the COVID ward. We managed to save him, and now he's come to you after 2020, he's come to you in 2022 or 23, and that's when you would still be finding deep Q waves in the ECG of the patient. For the 5th ECG finding, I'll just give a short description. Don't note it down. I mean, the theory part you need to note down, but don't try to note down the description. Just listen to it. In a normal individual, if you check out lead number V1, then the height of the R wave will be less than the depth of the S. Now, as you move towards lead number V3 in a normal person, you will notice that the height of the R and the depth of the S will be almost equal. When you go to lead number V6, you will notice that the height of the R will be more than the depth of the S. What you're noticing is, in a normal person, as you go from lead number V1 to V6, you will notice a gradual increase in the height of the R wave. I repeat again, in a normal person, as you go from lead number V1, in V1 R wave is chota sa, and then as you go towards V6, the height keeps on increasing. So you have is a gradual increase in the height of the R wave in a normal person as you go from V1 to V6. But if it's going to be a myocardial infarction patient, because there's going to be necrosis in the heart, there's going to be a, I would say, a negativity in the heart. So this increase in the height of the R wave will not be as fast as it happens in a normal individual. What I'm trying to teach you is, why is it written in literature of MI, non-progression or a poor progression of the R waves? The meaning of the word non-progression / poor progression of the R waves is that because there is negativity in the heart, the increase in the amplitude of the R wave that should occur from lead number V1 to V6, like in a normal person, this would not be happening. Either of the two can be written. Either he might say non-progression of R waves, or he might say is a poor progression of R waves. That simply means negativity in the heart. So the positive waves would be relatively smaller. So that's a series or sequence of ECG findings that would be occurring. In fact, I can just say that he can link it up from pathology perspective as well, because hyperacute T waves, T wave inversion, these are the findings which would be indicative. In fact, I can just put a line here to say that the initial two findings that I've described before you, they are suggestive of the fact that the person is suffering from a myocardial ischemia. And why I'm telling you this is because they try to link this up with pathology and physiology. And the question said, which of the following ECG finding is called as current of injury? CURRENT. Which of the following is the current of injury? Then the current of injury would be ST elevation in a patient. And then subsequently, I can say which of the following would be indicative of death. Then I've already told you cell death would be deep Q waves. Like this is how it happens in pathology. No, first you have ischemia, then you have injury, and then you have death. So that would be a sequence of events of ECG findings that would be developing in the patient. Next, I'll mention a disadvantage of ECG, which is that it is poor at localizing ischemia. Often in the MCQ, they'll give up multiple blood vessel names. I want you to remember that ECG is poor at localizing left circumflex artery ischemia. Now, why that is so is because the left circumflex artery would curl around the heart and then go posteriorly. So when it's curling around, that curvature part is not well read by the ECG electrodes. You can imagine the ECG electrodes like CCTV cameras, like every camera would be having a blind spot, like it can see in distance, but it may not be able to see immediately below it. So those precordial electrodes are good at picking a blockage anywhere in any coronary artery, but not where the area where the left circumflex artery is turning, which is why there's a possibility that if a person is having a lateral wall MI, which is at the turning point where the left circumflex artery is taking a curvature and there's a thrombus present, it may actually be missed. Because of this, we need to rely on cardiac biomarkers, and therefore the question will say what is the best test to confirm the diagnosis of MI. Obviously, the first test to be done is obviously ECG. But if he says, how are you going to be sure what's the investigational choice, then answer is cardiac biomarkers. And out of the various cardiac biomarkers which are used, we usually prefer troponins. Either we can check out troponin I or troponin T levels per se. A bit of physiology here. I mean, in one of the options that was asked with respect to troponin I, though I mentioned the remaining aspects for troponin I as well. The question said troponin I. What does I stand for? So troponin I stands for the fact that it is a regulatory protein. It inhibits the interaction of actin and myosin. And then you also need to remember that troponin actually binds to actin. It does not bind to myosin. It just binds to actin. That's just a physiology point that I would like you to remember. And whenever there is a myocardial necrosis, then the values will begin to rise. The rise will usually occur by 3 hours. You know, CPK-MB tends to rise by 4 to 6 hours. When I was a student your age, I used to read about CPK-MB being a preferred cardiac biomarker, but now it is troponin I/troponin T because they tend to rise relatively earlier. They will peak around the 24-hour period and they would remain elevated for 7 to 10 days. So you have is a rise, then a peak, and then a fall. So every time you read about myocardial infarction, you will always read the statement that there is going to be a rise and a fall in the value of cardiac biomarker like troponin I, and at least one value, with at least one value to be mentioned in the MCQ as more than 99th centile. I mean, if this statement is read by you ever, rise and fall of cardiac biomarkers and one value more than 99th centile of the upper reference limit, it is confirmatory that the patient is suffering from myocardial infarction. In fact, the terms that will be used to describe this troponin T and troponin I will be like a small c, that is for cardiac troponin I, and then troponin T levels. And as I've explained to you that you need to have one value above the 99th centile of the upper reference limit. As far as the current or the traditional kits that are available for picking up the values of troponin I or troponin T, they can detect values in the blood as little as about 1 nanogram per liter. I said the traditional kits for troponin I, troponin T, they can pick up values as little as 1 nanogram per liter. But you will also read about this troponin I ultra. Now, these are the new generation troponin I kits available where values as little as 0.04. I mean, look at the values that I'm talking about. Instead of saying 1 nanogram, I'm saying 0.04 nanogram per ml can even be picked up. So nowadays, in most of the hospitals, it is troponin I ultra that is being done because we want is the early diagnosis. You see, if a person is having values that are becoming double or triple, I mean, suppose you get a printout of a report that says value 0.04, 0.0, instead of 0.04, it says 0.08 or even higher than that, it is indicative of myocardial necrosis. So I am describing the same thing which I said for this rise and fall with value of at least one value of 99 centile of upper reference limit. This could also be written in MCQ as doubling of troponin I or tripling of troponin I. You could even have a 5-time elevation up to a 10 times elevation and even higher. I mean, in most cases of MI, they could be up to 50 to 100 times higher values of troponin I, whatever is the normal values, as compared to this 50 to 100 times higher. Though you could be having, all these are indicating like doubling, tripling, 5 times, 10 times, 100 times. They are indicating severity of myocardial infarction that is occurring in a patient. Now, before I write down the standard data of when do they rise, when do they fall, though I've said them verbally, I want you to remember that troponin I can be elevated because troponin I is excreted by the kidney. So I want you to remember that troponin I can be elevated even in patients who are having chronic kidney disease because it will not be excreted, which means the fact that suppose a CKD patient comes to you with chest pain and you're doing troponin I, the troponin I value comes out to be elevated. You are not sure about whether it is elevated because it was not getting excreted or whether it is a rise because of myocardial necrosis. So in a CKD patient, obviously ECG will play an important role. What I'm trying to teach you is a combination of ECG and troponin I should be used to confirm a diagnosis, but troponin I can be elevated in CKD patients even if the person is asymptomatic. And if he's symptomatic, then you have trouble in a sense that you will have to decide that whether the rise is because of the necrosis component or whether it is because that it was not getting excreted per se. I said ECG will resolve the issue for you. And over and above this, we can do a echocardiography also, because in MI, if you're having a myocardial necrosis, there would be regional motion defects that would be coming in the patient. Now, on a comparative basis, when you talk about CPK-MB tends to rise by approximately 4 to 6 hours. The peak values would be obtained by approximately 24 hours and then the fall would occur, and the fall of CPK-MB occurs by 48 to 72 hours. In contrast, when it comes to troponin I said it verbally initially, I'm repeating that once again, the rise would occur by something in the range of about 3 hours. In fact, if a person comes to the hospital early, like suppose in Delhi, there are so many cardiology hospitals, patient might come to the hospital within 1 hour of onset of MI, then tropi values will also be normal. They'll not show a significant rise. So you could be doing is a serial troponin I. What I mean by serial troponin I is a person comes to the hospital early, you can still make the diagnosis on basis of a ECG. But if you will repeat troponin I subsequently, you will notice that if you repeat it at, let me say, 6 hours after admission, it will show a rise if there is a myocardial necrosis. The peak value of troponins occur around about the same time, that is 24 hours. But when it comes to the fall would be approximately 7 to 10 days. So every time you get a question, what is the best test for diagnosis of myocardial infarction? Your answer would always be given as the ideal test for diagnosis is cardiac biomarkers. However, if he just tries to, introduce the word reinfarction, he says what test would be useful for diagnosis of reinfarction in a patient, especially after 72 hours, like after 3 days, person has had another episode. Now, if it is reinfarction after 3 days, then because CPK-MB will tend to come back to normal by the 3rd day and person had a MI on the 4th or the 5th day, it will rise again. So reinfarction after 3 days or after 72 hours, you can answer it as CPK-MB. But suppose it does not mention 3 days. He just says reinfarction in a patient. Now, my point is, it's not a guarantee, that reinfarction will occur after 3 days or 5 days or 7 days or 10 days only. So if he says the word reinfarction just like that, and he says that how would you be sure that there is a reinfarction, then when you do serial troponin I in the patient, you will notice that tropi values will begin to rise. So if the tropi values begin to rise by more than 20% over the admission value, at the admission value was already elevated. Now there is a substantial rise. Instead of 20% rise, let me say there's a 100% increase in the value of TROP-I, then I can say it is still a reinfarction in a person. So if he specifies 3 days, okay. Otherwise, if nothing is given, then troponin I would be the best way for diagnosis in the patient. And as far as CPKMB is concerned, why I mentioned it later is simply to tell you the fact that CPKMB can be present in skeletal muscle as well. In fact, though CPKMB is obviously more reliable as compared to CPK, creatinine phosphokinase, or in some MCQs, you might just have it written like this: CKMB divided by CK. Now, if this value is given to be more than 2.5, it means the fact that the possibility is that the rise is not due to myocardial necrosis, but the rise is mainly because of a skeletal muscle source. There was a skeletal muscle damage which could have explained this. And how did the skeletal muscle damage occur? I can say if a person was given cardioversion, then post-cardioversion, when the electrical current will travel through the heart, it will reset the rhythm of the heart, but it is traveling through the muscles of the chest. So therefore, you could be having is false elevations of CKMB, which again explains why it is not recommended nowadays. Instead of cardioversion, I can say that if a person has had any skeletal muscle injury, post myocarditis, person had COVID-19 myocarditis. And then subsequently, you could be having is a elevation of CKMB. Post cardiac surgery, again, this could be elevated. So my point is that as far as CPKMB/CKMB is concerned, you could find that the values could be elevated after the following scenarios. It could be cardioversion, where a high intensity DC shock of 200 joules was used, or myocarditis or cardiac surgery per se. So on a comparative basis, this would not be a very reliable way for diagnosis, especially if he mentions this particular value. It is telling you that the rise is not due to cardiac issue, but due to a non-cardiac issue. Now, before we go forwards, I also want to say, and this would be slightly contradicting the pathologist, because if he says what is first to rise in MI? Now, when I was a student your age, we always used to read that first to rise in myocardial infarction is myoglobin. My point is that, yeah, I will use myoglobin to identify, first to rise in MI, but there is no kit by which you can measure the value of myoglobin. So if he says what is the first marker to rise in patients of myocardial infarction, then your answer would be given as HFABP, that is heart fatty acid binding protein. Now, this is a test which is currently available in the EU or in United States, but my point is that we do have a kit available globally, heart fatty acid binding protein. The values of this can be actually rising as early as 1 hour after onset of MI, because the objective in medical science is early diagnosis. So that's why we are, as doctors, we are trying to improvise, we are trying to improve ourselves as compared to the previous years. When it comes to treatment, our objective is to minimize the mortality, because early diagnosis would facilitate reperfusion strategy to be instituted earlier as well in the patient. So heart fatty acid binding protein values, if they're elevated, they would help you in early diagnosis of myocardial infarction per se. And CPKMB is to be answered at the bottom of the list. And if he says what is last to rise in MI, in fact, I would consider that as a very useless multiple choice question, or it's only a theoretical exercise that we're doing, because if I'm waiting for last to rise, I'm literally waiting for death of the patient. So this is only for academic purposes that I'm mentioning that last to rise in myocardial infarction would be LDH, that is lactate dehydrogenase. But if he says what will be the first one to rise, your answer is heart fatty acid binding protein. And on a comparative basis, every time he says what is the best biomarker to be answered, it is cardiac troponins. If he says infarction, the answer is again troponins. And more importantly, you should remember for the current MCQs, he has to use this traditional phrase. This is just to make it sound sophisticated. Traditionally, I can just say the word doubling of troponin I, tripling of troponin I, but instead of saying that, he'll just make it sound sophisticated by saying rise and fall of value troponin I with at least one value more than 99th centile of the upper reference limit. So we can diagnose myocardial infarction on the basis of ECG and biomarkers. But over and above this, I also have some more strategies by which the damage to the heart can be identified. Like in case you are doing echocardiography in a patient, then you will be able to demonstrate motion abnormalities, because I can just use a English word here, stundmyocardium. you see sudden decrease in contractility of the heart because there is a sudden onset of thrombus occluding the coronary artery. So the heart, poor fellow, is stunned, and he is not able to respond to that, and therefore the contractility part is hampered. So every time you read about motion wall abnormalities on an echocardiography, which is obviously post chest pain episode in a person, then this indicates that there is damage in the heart. You can also be checking out the left ventricular ejection fraction. If it's anterior wall MI, this would be affected, and in case it's a right coronary artery getting involved, then the right ventricular function can also be checked. The advantage of echo is that it will also help you pick up a structural damage. When I describe the complications of MI, I will describe the structural damage, but yeah, you need to remember this ventricular aneurysm, which causes ST elevation, to be persistent. I'm saying this persistent. I mean, traditionally, or when I was describing ECG findings, I was saying, no, ST elevation will come back to normal with thrombolysis. But suppose you are having a patient where in spite of thrombolysis, ST elevation is persisting, then there can be only two possibilities. Either there is a failure of reperfusion, or if there is no failure of reperfusion, there is a structural damage in the heart. This is itself a question. Persistent ST elevation can be seen after MI in which of the following conditions? Then your first answer is obviously failure of thrombolysis. But suppose thrombolysis was never done. We did a PCI. And in spite of doing a PCI, I mean, you are on angiography, you can see the occluded artery. Then you do a balloon angioplasty and you destroy the thrombus and there is a reperfusion. So you have demonstrated angiographically that yes, there is a reperfusion, but still ECG is showing ST elevation. That means that there is a structural damage in the heart, which is in the form of a ventricular aneurysm, which is I would say a recipe for disaster, because in an aneurysm there could be clot formation, and these clots could go into the brain and could even cause the development of stroke in the patient as well. And if it's a full thickness infarction, then even pericardium can be involved. So on auscultation, you could be having is a pericardial friction rub, which I said is bad news because it tells you a full thickness infarction present. And if there is a pericarditis, even a pericardial effusion can be occurring in the person. Plus, you would be able to demonstrate structural damage. If he says what is the most common valvular lesion that is seen after myocardial infarction, then the most common valvular lesion that is seen after myocardial infarction is mitral regurgitation. This acute onset mitral regurgitation will cause damage to chordate tendineae. The chordate tendineae are structures on the undersurface of the heart valve that will snap, and that will cause leakage of blood from LV to LA. But my point is acute onset mitral regurgitation and damage to chordate tendineae can again be demonstrated on the basis of echocardiography. Over and above this, we also have nuclear scans. Now, this is obviously going to be more suitable for Western countries. Traditionally, I have described a thallium scan or a system UV scan to pick up a person who is having a blockage in his coronary artery. But even if there is a myocardial infarction, because it will cause necrosis in the heart, so therefore there would be a cold spot that would be demonstrated. I'm calling it cold because the uptake would be lesser. That's because there is a necrosis, there is a decreased blood supply present. And thallium system UV scan or even a gadolinium enhanced cardiac MRI. I mean, traditionally, we talk about gadolinium enhanced MRI of the head to pick up conditions like ring enhancing lesions like neurocysticercosis or cerebral toxoplasmosis or tuberculoma. But today I am talking about a gadolinium enhanced cardiac MRI. So in Western countries, they are using imaging techniques to obviously identify myocardial infarction in case you're not able to make a diagnosis with the traditional ways, like patient came very early, biomarkers are normal, symptoms are suggestive of MI, or let me say patient is a diabetic, is not having chest pain. But there is a possibility that in this person, there was, he did not complain of chest pain, but there would be hemodynamic alterations that would be occurring. He might have developed a syncope as well. So if you want to make an early diagnosis, you do have heart fatty acid binding protein. You can go in for a gadolinium enhanced cardiac MRI as well. And the logic here is that gadolinium does not enter tightly packed myocytes, but it can percolate into infarcted myocytes. I can repeat that again. Per se, gadolinium does not percolate tightly packed myocytes. I think that would suffice for you to remembering. I said normally there is no contrast uptake. It does not percolate tightly arranged. Anatomically, we have is a synoecium. We have is tightly packed cardiac myocytes. But if there is an infarction, then there could be a gadolinium uptake. That traditionally there would be no uptake, but if there is a uptake occurring in a localized area, that means that that area is infarcted, because the tightly packed myocytes, the anatomical, the tight junctions between those myocytes have been hampered due to myocardial ischemia. So these are other ways by which we can identify it. So if I just summarize, I said anybody having chest pain for more than 30 minutes with excessive sweating, you would do a ECG, you can do is a echocardiography, you can do cardiac biomarkers, which are the sure shot way, and apart from that, even a thallium scan showing a cold spot, or a gadolinium enhanced MRI showing a rather increased uptake, which normally should not be happening. These are findings which are suggestive of acute onset damage to the heart. We'll next focus on a couple of definitions for diagnosis of MI. One would be myocardial injury and second would be myocardial infarction. They're not the same. The technical meaning of the word injury would be, though I've already told you this, but still, you see, earlier I was telling you ECG findings of myocardial injury, hyperacute T waves, T wave inversion. But if they ask you per se definition of myocardial injury, then yeah, you do get ECG findings. But the technical answer would be what I've already said: rise and fall of the cardiac biomarker values like troponin I with at least one value more than 99 centile of the upper reference limit. The question then arises, what would be the meaning of the word acute myocardial infarction? Then for myocardial infarction, you not only need to demonstrate myocardial injury, but you need to demonstrate myocardial ischemia as well. So I'm going to jot down some points before you for the clinical evidence of myocardial ischemia. Now, the clinical pointers would be like, for example, a person could be having chest pain, or angiographically, I'm demonstrating that there is an obstruction in the coronary artery. So the couple of parameters which they have defined for evidence of myocardial ischemia, plus obviously myocardial injury. I repeat once again, what is myocardial infarction? It is a combo. It is a combination of myocardial ischemia plus myocardial injury. For myocardial injury, the rise and fall of cardiac troponin I that I've written earlier, and I'm repeating that once again. So you need to get the definitions right. If he just talks about biomarkers, you will say injury. Then what is MI? It is a combination. It is a combination of ischemia and the injury. And how do you know that this is myocardial ischemia? That I'll try to explain to you by a simple mnemonic, that is SCQMA. So let's just look at the technical definition that is given in the current edition of Harrison. The first point is very simple and straightforward. Anybody who's having symptoms of myocardial ischemia in the form of extreme chest pain, Levine sign, radiation to the jaw or radiation to the epigastric area, that's the clinical symptoms of myocardial ischemia. But why this definition has been created is because, like, diabetics may not be having standard chest pain. So how would you pick it up? Well, they might be having hemodynamic alterations. So in these patients, if you're having a new onset ECG changes, the sequence of which I've already explained to you, then you would say this is myocardial infarction in a patient. Or he has said that there is a development of, because I'm talking about silent MI also. So I'm saying if a person is having a development of pathological Q waves, I'm calling it pathological because Q waves are found in ECG of a normal person also. That would be a negative reflection before the R wave, and that would fit into one small square in the ECG. But if you have a Q wave which is spilling out either horizontally or vertically out of one small square. I said normally Q wave fits into one small square of the chota square of the ECG. If it spills out, if we would call it a pathological Q wave. So development of this indicates that yes, there is a myocardial infarction occurring in a person. Apart from this, you could also be doing imaging in a patient. For the imaging component, though this would be a repetition, I've already explained. I mean, either he would mention the word motion wall abnormalities. And why do these motion wall abnormalities appear? That's because there is less blood supply, there is loss of viable myocardium. I mean, the myocardium is supposed to contract, but if the blood supply is suddenly obstructed, then the poor fellow will not contract. So the imaging can help me pick it up. Or for that matter of fact, if I do angiography in a person, and angiography, I'm able to demonstrate that there is a big thrombus which is causing a physical obstruction of left anterior descending or right coronary artery or the left main coronary artery. If any one of these are present, then I'll say that yes, these are symptom of, this is a clinical evidence of myocardial ischemia. What is the clinical evidence? One could be presence of symptoms, as I explained to you. Then could be ECG findings that could be developing in a patient. Over and above this, there could be development of pathological Q waves. So SCQMA, I mean, that's a definition that's given in Harrison. So we need to remember this. Then is motion wall abnormalities in the myocardium. I've not written the word motion wall abnormalities, but I've written in the myocardium, there would be loss of viability, or let me just put it, jot it down also for you to remember it. Motion wall abnormality because of myocardial ischemia, and then angiography showing a presence of a thrombus. So let's just repeat this SCQMA, because he will definitely ask you this for the definition of myocardial infarction in a multiple choice question. You need to have at least any one of these. I mean, it's not that all of these should be present. Any one of these could be present. It could be symptoms. It could be new onset ECG findings. It could be pathological Q waves, like in case of a silent myocardial infarction. Then imaging showing motion wall abnormality, or angiography showing a presence of a thrombus, along with obviously the rise and fall of troponin I. I mean, any one of these and the rise and fall of troponin I is a diagnosis of myocardial infarction. I know it looks a little complicated at the moment. In simple English words, I can say anybody with chest pain, as I was saying earlier, with the Levine sign, with either ECG abnormalities or troponin I abnormality would be considered as a case of MI. I mean, that's how we identify it. But because there's a proper definition given in the textbook, so we need to remember that as well. Now, in the current edition of Harrison, is also mentioned the types of MI. By types of MI here, I do not mean anterior wall MI or posterior wall MI. We're not talking about surface localization, but we are talking about stuff like type 3 MI or type 4A MI. So let me just explain this to you. If a person is having a sudden onset, acute onset, atherothrombosis, that there is a big clot occluding the lumen of the coronary artery, and this person is having atherosclerotic risk factors, like the chap was having diabetes, or he was hypertensive, he was a smoker, and there's an acute atherothrombosis, I will say person is having type 1 myocardial infarction. But suppose a person is taking cocaine overdosage, then there would be a severe vasoconstriction, which could be so severe that it could trigger a myocardial infarction. So if there is a mismatch between the demand and the supply, this mismatch between demand and supply has been caused by external agents. The agent that I'm talking about could be either drug abuse, that is cocaine, or let me say if it is not cocaine person, it could simply be a grand multipara in India who's having severe anemia, and at the time of labor, she's not only going into heart failure, but she can even develop a MI. Let me say her hemoglobin is only 5 grams, 6 grams %. So the oxyhemoglobin would be too less in the body, and therefore the oxygen demand of the heart would be tremendous during the second stage of labor. Now this lady could suffer from MI when she is actually in labor per se, or if there is any vasospasm per se of the coronary artery. Like even in prinzmetal angina, rarely, I mean, that's not very common, but yes, in prinzmetal angina, there's a possibility person can develop a myocardial infarction, and that vasospasm, if it is causing MI, then it would be type 2 myocardial infarction in a patient. Difference between type 1 and type 2 would be that type 1 is mainly because of atherosclerotic risk factors, and if you have non-atherosclerotic risk factors, we would call it type 2 myocardial infarction. Type 3 is a very unfortunate patient in whom there would be a sudden cardiac death. I've explained to you that meaning of the word sudden would be that the person has died within 1 hour of either being heard, like he talked on cell phone to his son. His son stays in USA, and the father spoke to his son over the phone, and he says, half an hour ago, 1 hour ago, I spoke to my dad, he was okay, and now you're telling me my dad is dead or expired. Or like this guy walked into a gym and started doing some weights and he collapsed. So on CCTV camera, he was seen to be normal and then he expired. So sudden cardiac death is usually type 3 myocardial infarction. And obviously in this person, I'm saying that the person was rushed to the hospital where ECG was done. So ECG changes were very much present. The ECG changes were very much present, but cardiac troponin sample was drawn because cardiac troponin I or T, the turnaround time is about 1 hour. You know, if you send the lab sample to the lab for a estimation, quantification, you may not get a report immediately. So if you are having demonstration of ECG changes in a person and there was chest pain in the person when he crashed in the gym, or let me say did not even complain anything, he just fell down and he was brought to the hospital, ECG changes were present. So we'll take that test elevation to be that of myocardial infarction even before the biomarkers are available. You know, the troponin I turnover time would be, at least if I'm saying 1 hour, it looks a little far-fetched to you. If you're working in a tertiary care hospital, you say, sir, we do it within minutes. I agree to that. So my point is, before the values are available, even if it is couple of minutes, the person has expired, then we'll take that to be type 3 myocardial infarction. And then there is a new entry in the current edition of Harrison, that is type 4A, 4B and 4C. I mean, in the previous edition in the app, you would have heard me talking about 4A and 4B, but never about 4C. So fairly, I would say, interested. Type 4A myocardial infarction would be PCI related. Like you have done a balloon angioplasty in a patient. The thought process is balloon angioplasty should open up the thrombus. But the bad news is you are deploying a balloon, which is a foreign material in the blood vessel. So the balloon itself can trigger a clot formation. It will destroy the original thrombus, but once you deflate it, because your balloon caused damage to the endothelium of the blood vessel, it could cause a development of another thrombus in the coronary artery after the one that was originally present was removed by you. So PCI related myocardial infarction, that is why we take consent. Every time you're doing a PCI procedure in a person, you always take a consent that this procedure itself can trigger a myocardial infarction. So that's the bad news with the procedure. And if it causes it, we call it type 4A myocardial infarction. On the other hand, you will also hear about people saying that, you see, my dad had a stenting done 10 years ago, 15 years ago, but now he had a MI. So if a person is already having a stent in the heart, he is already having a stent in the heart, and then there is a MI occurring, that could be a latent stent thrombosis. That the stent is after all a foreign material. No, agreed that nowadays we put a drug-eluting stent which would be having coating of sirolimus or everolimus, but in older times we were having bare metal stents. So if this person got a bare metal stent deployed, let me say 10 years ago, and it develops a MI currently, we will call it a type 4B myocardial infarction. Type 4C is related to restenosis. That is, this person, he had maybe a chronic stable angina, he had undergone a balloon angioplasty, and now there was a restenosis at the same site where there was an obstruction in the coronary artery, which was so severe that it caused a complete luminal obstruction. Type 5 myocardial infarction would be unluckiest out of all of these patients. Here developed a MI with respect to coronary artery bypass grafting. Now, this looks very surprising because the query of most of you would be, sir, CABG is the preferred treatment for triple vessel disease. You are saying it is causing MI. You see, any procedure, if you're operating on the coronary artery, beating heart or non-beating heart, my point is, after all, the cardiothoracic surgeon is putting sutures in the coronary artery because he's doing a vascular anastomosis. Those sutures are also foreign material, no? So they can also trigger a thrombus formation. So unfortunately, a patient can develop a type 5 myocardial infarction during a coronary artery bypass grafting as well. And well, out of these, I want you to remember at least two data, which is that in type 4A myocardial infarction, the values of troponin I will be at least 5 times elevated. Whereas when it comes to a type 5 myocardial infarction, the troponin I values would be at least up to 10 times elevated. You need to remember this information, that 5 times elevation is not seen with type 5 MI. I repeat my words once again. 5 times elevation is not seen with type 5 MI. 5 times elevation is seen with type 4A myocardial infarction. If he says 10 times elevation, I told you the cutoff levels with respect to the kits, because we can do quantification. So I told you that the cutoffs which are available are like, for troponin I ultra, it would be as little as 0.04 nanogram per ml. So my point is that in a person, if you are having is a demonstration of rise and fall of biomarkers with SECMA, that is symptoms, ECG changes, pathological QVs, motion wall abnormalities, angiographic evidence, it is MI. And this that I've explained to you is etiology-wise classification. This is why MI occurred in a patient. Was it atherosclerosis primarily? 20-year-old guy went to a rave party. He did drugs. His drug peddler gave him cocaine and he was super excited. He took extra dose of cocaine. That could be type 2 myocardial infarction. Sudden death, that is type 3. Then for exam purposes, at least two informations which are a must know for you are type 4A and type 5 MI. Just try to remember this, how you will remember 5 times elevation of TROP-I is not seen with type 5 MI, it is type 4A, and rather with type 5 MI, it is at 10 times elevation. These are details that I want you to remember for universal definition of MI. There's a separate table in Harrison, which they would love to ask you in the exam in case they decide to quiz you on this topic. We shall now focus on two common ECGs of myocardial infarction that are given in the exam. In the very first one, students of mine, when they were recalling the paper with me, they told that in lead number 2, lead number 3 and lead number AVF, they were able to pick up this classical ST elevation with a convexity in an upward direction, that is Pardee sign or tombstone pattern. In case you get ST elevation present here, your clinical diagnosis would be that of inferior wall MI. And in one of the sessions, he rather asked which blood vessel is the culprit vessel. The word was culprit vessel. Then answer is right coronary artery would be having is a thrombotic occlusion, which would be a fibrin-rich clot, which will explain why fibrinolysis would be used in this case of ST elevation MI. In the second oft repeated ECG, the students of mine told that they were able to pick up very classical ST elevation in lead number V1, V2, V3, V4, and then look at it carefully. You are even able to pick up this ST elevation even in lead number V5 and V6, which tells you the fact that this particular patient is having an extensive, in the options, anterior wall MI was also given, and extensive anterior wall myocardial infarction was also given. So the diagnosis of yours in this case would be that the blood vessel, which is the culprit vessel, is the left main coronary artery, which is having a thrombotic occlusion, which is explaining the ST elevation MI that has occurred in this case. Now, once you get this right, we'll next focus on what is the treatment initial to be given to the case and what are the basic protocols to be followed. MOAN is a common mnemonic that you know from your pharma classes as well, that is morphine, oxygen, aspirin, and nitrates. But let's look at how would we be going about administering this. And suppose he asks in the exam what is the treatment of choice for any case of ST elevation MI, then my answer would be given as going ahead with a primary percutaneous coronary intervention, where I'm going to do a coronary angiography. I'm going to see which blood vessel is thrombosed, and in that artery we're going to deploy a balloon and get rid of the thrombus. In primary percutaneous coronary intervention, the guidelines are door to balloon time, or instead of door to balloon time, they'll call it FMC, that is first medical contact to device time. The bottom line is that the device here means that you are deploying a balloon in the coronary artery and getting rid of the occlusion which is present. So the first medical contact to device time should be kept under 90 minutes so that we are able to get optimal outcomes. Why am I talking about optimal outcome here, or why am I focusing on this 90-minute period, is just that they've shown in clinical studies that the tendency to develop tachyarrhythmias is fairly common in the first few hours after onset of MI. So therefore we want to minimize the chances of both out of hospital and in hospital mortality in a patient. Now suppose you are having, or you are working in a smaller hospital which is not having a PCI capability, or let me say it is having a PCI capability but is available, PCI facilities are only available till 4 p.m. or 5 p.m. in the evening, and then the consultant who's doing it is staying a distance away and the cath lab is closed. If you are working in a non-PCI capable hospital, then your objective for door in and door out, what I mean by door in and door out is patient came to the hospital right now, let me say 4 p.m. in the evening, then we should be able to initiate thrombolysis in the patient. The thrombolysis will be done with multiple drugs. It could be streptokinase, L-teplase, tenecteplase, reteplase. I'll mention the names only. But my point is, as far as in a non-PCI capable hospital, when it comes to performing fibrinolysis in a patient, earlier they were using the word thrombolysis, now they're focusing on the word fibrinolysis, then this fibrinolysis should be done within 30 minutes of arrival of the patient, or I would say admission into the hospital. In that 30 minutes, you need to do all the baseline workup of the patient, that is a ECG and a cardiac biomarker, and if possible echocardiography, and then once you make a diagnosis, you would be going ahead with the treatments that I mentioned. The most important aspects that I would like you to remember is the time frames that I mentioned. If you're working in a PCI equipped hospital, you would be doing a balloon angioplasty and getting rid of the obstruction within 90 minutes, or once the patient has made first medical contact. In case of thrombolysis, you need to do everything fast within 30 minutes. If they ask you the upper limit of thrombolysis, that's a huge 12 hours. I'll talk about that upper limit of thrombolysis as we progress, but there are two separate aspects which I want you to understand. Suppose a patient suffers from MI at 8 a.m. in the morning. Then if he comes at 9 a.m. or 10 a.m. or 11 a.m., that is his choice. Suppose he comes at 11, you will do thrombolysis by as early as 11:30. Similarly, if he comes at 12, you will do thrombolysis by 12:30. But then I said verbally, upper limit of thrombolysis. Till what time of the onset of MI can you do a thrombolysis? That would be a huge 12 hours. I repeat that statement of mine once again, guys. Upper limit for thrombolysis. That means if a person had MI at 8 a.m. in the morning, then you can be doing thrombolysis up to 8 p.m. in the evening. Suppose he came at 7 p.m., you will do within half an hour of arrival. So there are two separate aspects. For the doctor, he has to do thrombolysis or start fibrinolysis within 30 minutes of the patient being admitted. But the upper limit for fibrinolysis should be answered as 12 hours. That is, heart is fairly resistant to hypoxia. You will notice that when I'll be teaching you acute ischemic stroke, the upper limit for thrombolysis would be answered as 4.5 to 6 hours. I mean 4.5 would be the best optimal answer for acute ischemic stroke. But for myocardial infarction, fibrinolysis upper limit would be answered as 12 hours. Now, the mnemonic that you're familiar with from your pharma classes is MONA or MON, but we don't actually start with morphine. If he says, what are you going to do in the patient? Because ultimately it's going to be a clot which is going to be triggered by platelets. So the first thing that we're going to do in the patient is start with aspirin, and this would be a 325 milligram chewable tablet. So you'll be asking your nurse to instruct the patient, or if you are yourself handling the case, you'll instruct the patient to crush the tablet between the teeth. The range or the dosage will vary from 160 to 325 milligram, and then subsequently, I mean, once he's on the road to recovery, then subsequently the dosage that you will be giving to the patient will be in the range of about 75 to 162 milligrams. I repeat once again, initiation of treatment would be a 160 to 325 milligram tablet chewable. I mean, no, they would not ask you the dose, and subsequently on the road to recovery daily he has to take aspirin to prevent an episode, baby aspirin I can call it, to prevent development of episode of MI once again. The main objective of giving aspirin would be that this would be a COX-1 inhibitor, and at the same time it's going to inhibit the production of thromboxane A2, which would be causing platelet aggregation. So I want to inhibit progression of thrombus formation. Over and above this, I want you to remember that in patients who are gonna undergo percutaneous coronary intervention, because most of the time we are having cath lab facilities available and government is ramping up facilities for a PCI. So current guidelines are that we should be actually giving two antiplatelet drugs. He is rather nowadays talking about DAPT, that is dual antiplatelet therapy, to be given to patients of myocardial infarction. So the second, what would be the second drug that would be administered to the patient? Then the second drug that we can give to the patient is ticagrelor. We can also use clopidogrel. That's okay. But in Asian population, the clopidogrel, because it's a prodrug, because of various genetic polymorphisms, the response may not be so good. So it is aspirin and ticagrelor 180 milligram. That those would not matter, but aspirin and ticagrelor is one that is recommended. And when would you be recommending a dual antiplatelet therapy? In those patients who are gonna undergo a percutaneous coronary intervention, which is going to be the norm in majority of cases. Within 90 minutes we should be doing this percutaneous coronary intervention. And now once your nurse has given chewable aspirin with ticagrelor to the patient, comes the role of giving oxygen. Well, would you give oxygen in all cases? No. You will be putting in a pulse oximeter and checking out the SpO2 of the patient. If the SpO2 of the patient is less than 93%, that is when oxygen would be administered, and you can administer this oxygen either with help of nasal prongs, or instead of nasal prongs you could be using the traditional Hudson face mask. And the flow of oxygen, or the flow rate of oxygen, would be usually kept at about 2 to 4 liters per minute. So what I want to say is that if person is not having pulmonary edema, if there is no desaturation at the movement, or let me say if it's an inferior MI where you would not be having a pulmonary edema, then you may not be requiring oxygen, and you can manage the patient on room air as well. The next thing to be given to the patient is not going to be answered as morphine again. Your answer is going to be anti-ischemia agent to be deployed, that is sublingual nitroglycerin. 0.4 milligram would be given sublingually to the patient. You can give it a total of 3 times, and you would not give all the tablets simultaneously. I mean, these would be given at intervals of 5 minutes each. So it's like one tablet, then after 5 minutes another one, and repeated, total 3 over 15 minutes. Now the point is that sublingual nitroglycerin is a powerful venodilator. So this would be contraindicated if the systolic blood pressure of the patient is less than 90 millimeters of mercury, because I said it's a venodilator. I mean, if you lose systolic blood pressure, you have is a further reduction of coronary perfusion and reduction of cerebral blood flow, reduction of the renal blood flow as well. Sublingual nitroglycerin is also contraindicated in cases of inferior wall MI. Remember I told you inferior wall MI has a vagal stimulation and there would be a concomitant bradycardia occurring in a patient with hypotension. So if BP is already low, then you would not be comfortable giving sublingual nitroglycerin to the patient. Similarly, this medicine would also be contraindicated if a patient has taken phosphodiesterase 5 inhibitors. That would be for erectile dysfunction. Like this person is 65-70 years of age. For ED, he takes Viagra, that is sildenafil. So if a person has taken phosphodiesterase 5 inhibitors in the last 24 hours, then again this medicine would not be given. The logic is pretty straightforward. In ED, when you are giving Viagra or sildenafil to the patient, it would cause a local levels of nitrates to be elevated in the patient. In a person who's already having nitrates values elevated in his blood, if you're gonna give more nitrates, then it can cause systemic hypotension. And that would be counterproductive because already there's a thrombus in the coronary artery. If you lose blood pressure, then the coronary blood flow in the patient would also be reduced. Sublingual nitroglycerin sometimes can cause a idiosyncratic fall in blood pressure. In case there is a idiosyncratic fall of blood pressure with sublingual nitroglycerin, the fall of blood pressure is very substantial, then you can be using atropine to neutralize this idiosyncratic fall of blood pressure with sublingual nitroglycerin. Now comes the important drug, that is morphine. And why are you giving morphine to a patient of MI is not only for that it is a good analgesic, but morphine also reduces pulmonary edema. Because if you read pharmacology, it causes shunting of blood from the pulmonary circuit to the systemic circuit. So it's reducing pulmonary edema. So you would be giving is a 2 to 4 milligram intravenous shot of morphine. And the advantage of this would be that pulmonary edema component would be reduced. But at the same time, morphine again can cause hypotension. It can even contribute to bradycardia because of the vagotonic action. And you will notice that when you give morphine to a patient, a lot of patients might actually have vomiting also. So because of the vagotonic action, bradycardia component and heart rate would become lesser. If he says, what would you do if morphine administration is causing lowering of BP of the patient? Your answer would be raise the legs of the patient and give a bit of fluids to the patient, and if required you might have to give atropine to the patient as well. You see, I said you could be having is a fall of idiosyncratic reaction where there might be a precipitous fall of blood pressure with nitrates and even with morphine as well. So you need, at least one nursing staff of yours to be standing by the side of the patient just to alert you to this fact that if there's a sudden drop in blood pressure or there's any tachyarrhythmia coming up, which you will obviously see on the monitor because the patient would be hooked up to a monitor. But that blood pressure aspect, I would like you to especially be very careful, especially with respect to nitrates and morphine. Now comes the role of beta blockers. Studies have shown that a single dose of beta blocker will reduce the infarct size. And what is the beta blocker that would usually be recommended? That is the time-tested molecule, that is metoprolol, that would be administered to a patient. The only problem is metoprolol would be contraindicated in case it is an inferior wall MI. So I want you to remember this fact. Nitrates are contraindicated in inferior wall MI. Why? Because BP is low. And then beta blockers are contraindicated in inferior wall MI. Why? Because heart rate is less. Because in inferior wall MI, vagal stimulation occurs, so there's a bradycardia. And if somebody is already having a bradycardia and you're gonna give a beta blocker to the patient, it can be counterproductive because the blood pressure will drop. Similarly, if a person has developed heart blocks, like after myocardial infarction, there was damage to the conduction system of the heart and the person has developed, let me say, Morbid's 2 heart block or any heart block per se, the heart rate will become less than 60 and you are going to use beta blockers in a chap with heart rate less than 60, then God help this patient. Similarly, beta blockers are also contraindicated in acute congestive heart failure. So if a person has already landed in heart failure, then beta blockers would not be given. So you need to know these aspects. For 3 and 4, I explained it is mainly the fall in blood pressure that has to be taken care of. In case it's gonna be beta blockers, then the contraindications to beta blockers must be ruled out before you administer this. But at the same time, I said that beta blockers have been shown substantially to reduce infarct size because they will reduce oxygen consumption of the heart. The next molecule that would be used in the patient is low molecular weight heparin. We can use traditional plain heparin also, that is unfractionated heparin or low molecular weight heparin. This molecule is especially useful if thrombolysis is planned. Like suppose you are working in a non-PCI equipped hospital and you're planning to do thrombolysis slash fibrolysis in a patient, then heparin would be I would say a advantage to you. One, because it has been shown in clinical studies that when you give heparin to a patient along with thrombolysis component, it will reduce the incidence of non-fatal reinfarction. You see, I said after MI there can be a reinfarction also after 72 hours where I'll use CPKMB for diagnosis, but then heparin has been shown to reduce the incidence of a reinfarction. At the same time, it will also reduce the incidence of embolism. By embolism, I mean that suppose a patient has had a structural damage to the heart and it has caused a LV aneurysm. Now there could be a clot formation or clots formation and they could go to the brain and can cause stroke in a patient. So heparin has been shown to reduce the incidence of stroke post myocardial infarction in a patient. Because majority of our patients are anyway hypertensive, so ACE inhibitors, RAS blockade would anyway be a welcome step because they would be due to intense pain, a vasoconstriction occurring in the body due to sympathomimetic stimulation. So ACE inhibitors or ARB are to be used, but this is only if there is hemodynamic stability. This is only to be used if the systolic blood pressure of the patient is more than 100 millimeters of mercury. Otherwise, RAS blockade is not recommended. Any hypotensive patient of MI, no, ACE inhibitors would not be given. Only if, I'm just putting it, if here, use them only if the systolic blood pressure is more than, you are having good tissue perfusion. At the same time, because a lot of patients would be diabetic, so based on the sliding scale, you might have to give insulin to the patient. You need to keep a watch on the electrolytes, especially potassium and magnesium, because they can trigger tachyarrhythmias. Hypokalemia, hypomagnesemia can trigger Torsades de Pointes. So monitoring of electrolytes would anyway be important. And these would be basic therapy that you will be using for the patient, that is MON, but you don't start with morphine, you start with aspirin. I spoke about dual antiplatelet therapy. I'll be giving oxygen to the patient if required based on the oxygen saturation values, plus we'll be using sublingual nitroglycerin in the patient, 3 shots, and then is morphine, beta blockers. Lots of time if morphine is not available, like in government hospitals, if morphine is not available, you straight away can use beta blockers. This is itself a question that can be asked to in your ward, that if morphine is not available, what would you give to the patient? So I'll give a beta blocker because it will reduce the, nitrates have already given, but the chest pain you would usually not get resolved by it. The severity of chest pain in MI would be so much that you need a good analgesic effect with morphine. But suppose it's not available, okay, I'm going to downgrade the oxygen consumption of the heart by use of beta blockers. Heparin in case I'm not planning a PCI, I'm planning a fibrinolysis, and then control the blood pressure and good sugar control would be mandatory. And subsequently we're going to plan a PCI, that is a percutaneous coronary intervention in the patient within 90 minutes of arrival. Now I'm creating a scenario before you where he says that a patient is came to a non-PCI capable hospital and is being shifted to a PCI capable hospital. Then obviously, because it will take a little time for transportation as well. So if he says that in a PCI capable hospital, PCI should be then done within, the answer would be 120 minutes. I repeat my statement. If he is straight away taken to a PCI capable hospital, no issues, within 90 minutes, you would be doing is a balloon angioplasty, getting rid of the thrombus occluding the artery. If is taken to a non-PCI equipped hospital, we'll be doing a fibrinolysis. The door in, door out time would be 30 minutes. But if it's a transfer from a non-PCI to a PCI capable hospital, then yes, we need to incorporate the transit time as well, and your answer would change over to 120 minutes. Let's just focus on what are the fibrinolytics that are available for management at the moment. So we can be using tissue plasminogen activator, that is L-teplase. L-teplase would be the preferred molecule in both management of patients of acute ischemic stroke as well in patients of ST elevation MI. We can be using streptokinase. In fact, here I can incorporate a question from microbiology. The question said streptokinase is isolated from which bacteria? Everybody answered streptococcus, but then which group of streptococcus? Because we have group A, B, C, D. So your answer would be given as group C streptococcus is from where we isolate streptokinase, and this also explains the chances of development of anaphylaxis. We do not have anaphylaxis risk with the TPA or other thrombolytic drugs, but with streptokinase we have an anaphylaxis risk because we are already exposed to this bacteria per se and the antigenic stimulation is already present. The other drugs that we shall be using in the patient would be like tenecteplase, or we can be using retaplase. And the advantage of both the molecules is that they can be given in the form of a bolus as well. You see, for L-teplase and streptokinase, you need to set up a drip. And setting up a drip, you need a trained nurse. So nowadays, there is a rather, I would say, a trend to use bolus fibrinolytics because of ease of administration as well. I mean, you just give it directly into the IV cannula. So tenecteplase and retaplase should be remembered from the pharmacological perspective as bolus fibrinolytic drugs. So next I'm going to describe to you is contraindications for fibrinolysis. And at this point of time, I want to remind you that the biggest side effect with the usage of this fibrinolytic drugs is bleeding. And by bleeding, I do not mean bleeding from the nose. It could be a CNS bleed as well. So let's make a list of absolute contraindications as far as thrombolysis in a case of ST elevation MI is concerned. If a person is having active internal bleeding, like this person is already on warfarin and is having warfarin toxicity, it has already contributed to a gross derangement in the coagulogram and is having an active CNS bleed, internal bleeding, then I would not be going ahead with thrombolysis in a patient. 1 and 2 practically would be easy to pick up in any MCQ. I mean, if a person has suffered from an intracranial hemorrhage at any point of time, it could be intracranial hemorrhage maybe 6 months ago. He's not having a CNS bleed right now, but he had a CNS bleed 6 months ago. If I do thrombolysis in this person, then the good news is I will get rid of the obstruction in the coronary artery, but the bad news is he could bleed in his brain once again. So in a person who's already suffered from hemorrhagic stroke, I would not try to go ahead with thrombolysis. Similarly, if on admission the blood pressure is more than 180 by 110, you see, I can lower the BP by using drugs, like I can be using beta blockers anyway. I'm giving metoprolol, that should help. I'm using ACE inhibitor in the person, that should help. Otherwise, I might have to use labetalol, or if required, I can be using drugs like nicardipine. But my point is, if a person is already having an elevated blood pressure and you do thrombolysis, it's a recipe for disaster, because the biggest side effect of thrombolysis is bleeding. And in a hypertensive patient, the bleeding can be life-threatening as well. And then if a person has already received streptokinase, like he had a MI, let me say 1 month ago, and now is again admitted with MI, and you are reusing streptokinase in a patient, then the risk of allergy would be present. So he says in the textbook that don't reuse streptokinase, in a sense that chances of anaphylactic shock that will cause laryngeal edema. And laryngeal edema, you very well know, I mean, it can be causing difficulty in intubation, so you won't be able to secure the airway also. And lots of time, even if you give adrenaline undiluted 1:1000 intramuscular for anaphylactic shock, the person, once he goes into anaphylactic shock, it's a one-way journey to hell, I would say, that the person is not able to recover. So I would not like to take a chance. Actually, in private practice, I'll put it like this, that if streptokinase has been given once, then don't use ever again. You can use alteplase, you can use tenecteplase, which are manufactured by DNA recombinant technology. But in Harrison, because he's talking about ideal scenario, he says do not reuse if received in the last 5 days to 2 years. I mean, he says that after 2 years, the hypersensitivity and causing antibodies tend to become lesser in titer, so you could be using it. But I said from an ideal perspective, to avoid medical legal cases, if streptokinase has been used in a patient once, then ideally speaking it should not be used, though I need to quote the textbook, that is up to 2 years. Then I will mention some relative contraindications as far as thrombolysis in myocardial infarction is concerned. If the international normalized ratio of the patient is more than 2, then chances of CNS bleeding would be increased. If a person has received prolonged CPR, the definition of prolonged CPR is CPR for more than 10 minutes, then the damage has already occurred in the brain. I can say that brain can resist hypoxia only for 4 minutes. If a patient has had requirement of CPR for more than 2 times of that 4-minute limit that I told you, CPR for 10 minutes or so, that irreversible damage has already been done. If a person has undergone any invasive procedure, now if he has undergone any kind of a invasive procedure in the previous 2 weeks, then this would be a relative contraindication for performing thrombolysis. Similarly, if he's having bleeding diathesis, why am I calling it a relative one is because if he's having a bleeding tendency, I can correct it also, no? I can correct the bleeding tendency. Like suppose platelet count is lesser, I can give platelets. If it is a deranged coagulogram in a person, I can get it back to normal with help of vitamin K or fresh frozen plasma or prothrombin complex concentrates, depending on the situation. Like for warfarin toxicity and there's a potential risk for IC bleed, I can be giving prothrombin complex concentrate in the patient also. Similarly, if a patient is having a hemorrhagic diabetic retinopathy, now I can say that heart is more important than eye. To explain this, I can say if a person is already had a hemorrhagic diabetic retinopathy, then because I said heart is more important than the eye, I mean I am ready to lose the eye. That is why I'm calling it relative. But the bad news is, I mean, you saved the heart but make the patient blind. So it is therefore going to be classified as a relative contraindication. Out of the ones that I've listed here before you, approximately 8 of them, at least the top 4 that I've written, at least 1 and 2, nobody will have an issue, because the moment you read the word bleeding, the alarm bells are on, because the biggest side effect of thrombolytic drugs is development of bleeding. But for 3 and 4, I would like you to remember that if a person has had a high blood pressure, if the streptokinase has been used previously in a patient, or I can add one more to this, that is aortic dissection. Because if a person is having a tear in the aorta, then he will also experience chest pain, but the chest pain would be mainly concentrated in the interscapular area, and I'll have to do a CT angiography to pick up whether it is type A or type B aortic dissection. But then there are 2 A's present here: active internal bleeding, aortic dissection, and the remaining one, the bleeding word, is anyway easy to pick up: high blood pressure and streptokinase because of risk of anaphylaxis are contraindications, absolute contraindications for performing thrombolysis in a patient. For anaphylaxis, if he says what is the main antidote, your answer is intramuscular adrenaline. You will not get time to dilute it, so you'll break the ampule, and undiluted adrenaline. Mark my words there. The only scenario in emergency medicine where you're using undiluted adrenaline. In cardiac arrest, it's always diluted adrenaline. The only scenario in emergency medicine where you use undiluted adrenaline is anaphylactic shock. And in case you are not able to, in case you are not able to act on time, then there is a high probability of expiry of the patient due to, in the exam, laryngospasm was also given and laryngeal edema was also given. A lot of guys casually answered laryngospasm. It is laryngospasm is the cause of death in tetany. But in anaphylactic shock, the cause of death is going to be laryngeal edema. So you need to remember absolute contraindication for fibrinolysis when it comes to myocardial infarction, and bolus fibrinolytics to be remembered are tenecteplase and retaplase. Next we shall talk about is complications after myocardial infarction. If he says what is going to be the most common one after MI, then do not answer heart failure. Yes, it can occur, but overall the most common one and the earliest one to occur would be development of tachyarrhythmias / bradyarrhythmias in a patient, with tachyarrhythmias being relatively more common. He will trouble you with a couple of rhythm disorders. He might say what drug would be used if a person after MI is having multiple premature ventricular contractions. You see, PVCs can occur especially after the age of 40 years and would not require any treatment. But post MI, if you are able to demonstrate multiple PVCs, then they can deteriorate into a ventricular tachycardia. So he says what drug should be given. The language of the question will be post MI patient. He has already been treated with either fibrinolysis or he has been treated with PCI and he's having multiple PVCs. What drug would be given? Your answer would be given as beta blockers. But if a person is having a sustained ventricular tachycardia, you see, if he goes into a pulseless ventricular tachycardia, you obviously need to go ahead with defibrillation in the patient. This defibrillation would be 200 joules and you'll have to repeat it. The drugs that can be given after this defibrillation and still he persists in ventricular fibrillation can be epinephrine. Another drug that can be given is amiodarone. I've described the treatment for management of pulseless ventricular tachycardia even in advanced cardiac life support discussion, which is in the emergency medicine section. You first give a DC shock. The second DC shock that you have to give, you would also be giving drug support, that is epinephrine and amiodarone. The main advantage of using these drugs is, why are you giving epinephrine or amiodarone in a patient of pulseless ventricular tachycardia / ventricular fibrillation? That is because these drugs tend to increase the response to the DC shock. I repeat my statement once again. In a patient who's having a pulseless ventricular tachycardia or a ventricular fibrillation, why do you give epinephrine? Because epinephrine or adrenaline is for cardiac arrest, but you are giving epinephrine in advanced cardiac life support support to a person who's having a pulseless ventricular tachycardia because it increases the responsiveness to the next DC shock that would be given to a patient. And total, how many DC shocks can you give? Then you can give in the protocol only 3. I mean, the first one, then the second one with the drug, and in case, I mean, there's no incremental power that is being used currently. It would be standard 200 joules, 200 joules, but drug support tends to increase the response to electroshock. If it says sustained ventricular tachycardia, I think I give you sufficient time to plan it out. The answer of yours could be given as amiodaron. In the previous edition of the app and in the previous books, it was mentioned lignocaine for post-MI ventricular sustained ventricular tachycardia. But in the current edition of the textbook, he has categorically mentioned that post-MI patient, if he's having a sustained ventricular tachycardia, you do not use lignocaine, you rather use amiodaron in the patient. If it is torsades de pointes, then you need to treat the cause. Yes, please remember that torsades de pointes is mainly triggered by tachyarrhythmias, which could be triggered by, it's a tachyarrhythmia which could be triggered by like hypokalemia or hypomagnesemia. So electrolyte imbalance could be present. And why that electrolyte imbalance? Because if a person is having pulmonary edema, you might be using furosemide, and the diuretic usage could be responsible for hypokalemia, which has resulted in then a tachyarrhythmia in a patient. Then is a tachyarrhythmia which is very harmless one, that is AIVR. AIVR would be called as accelerated idioventricular rhythm. I said this is a harmless rhythm. In fact, accelerated idioventricular rhythm is good news. Good news in a sense that this is written in the textbook as a reperfusion arrhythmia. He says that if this is going to occur, it tells you indirectly that the coronary artery, which was blocked with the thrombus, has opened up and the reperfusion in the coronary artery has started. So the language of the question was, and this is an old AIPG question. I mean, now we call it NEET. Earlier they used to call it AIPG, All India PG Entrance. Then reperfusion arrhythmia seen after thrombolysis. The question was reperfusion arrhythmia which is seen after thrombolysis. The answer would be given as accelerated idioventricular rhythm. In simple English, it can also be called as slow VT, because the ECG findings of AIVR look like that of VT, but because there is no tachyarrhythmia, heart rate in AIVR is only between 60 to 100 beats per minute, and that is what is present in you and me also. That is why I was saying it is harmless. Similarly, if a person is having sinus tachycardia, we can be using a beta blocker. If there is a sinus bradycardia in a patient, then you will be having to use atropine. And if atropine is not working, then you will have to go in for transcutaneous pacer deployment in a patient or a transvenous pacer deployment in a patient. And as far as management of symptomatic bradycardia is concerned, there's a separate video again in the cardiology section that you need to go through. So the most common complication that is seen after MI would be development of arrhythmias. And in case it is not arrhythmias, then it could be a development of pump failure in a patient. Why pump failure? Because you see the myocardium is suffering from ischemia. Stunned myocardium is not able to generate proper pumping activity. In case there is a pump failure in a patient, then it would mean that congestive heart failure findings would be developing in a patient. Pulmonary edema will gradually increase to the level patient can develop pink frothy sputum as well. So he has given a special classification here, which is called as Killip classification, to grade the severity of heart failure that is developing in a patient. If he says Killip classification, I'll start from the worst of scenario. I mean, that would be relatively easier for you to comprehend. That Killip classification 4 would mean that the systolic blood pressure, I mean the left ventricle of the patient is not working, so the systolic blood pressure of the patient would be falling, and therefore coronary perfusion would also be reduced. But if a person is having presence of severe pulmonary edema, how do I know it is severe pulmonary edema? That in both the lung fields, both in let me say infraaxillary areas, inframammary, supramammary areas, in all the lung fields, wherever you are putting your stethoscope, you are able to hear crackles in the chest. That would be severe pulmonary edema, which means that the prognosis would be relatively worse off. But if a person is having crackles only at the lung basis, then I am gonna say that the pulmonary edema is still the lower part, and then gradually will increase upwards. So crackles which are present mainly on the lung basis, that would be Killip classification stage 2. And in case it is gonna be Killip classification stage 1, then at the moment no features, or I would say no signs of pulmonary venous congestion have appeared. My point is, in case a person is having a left ventricular failure, then this would cause congestion in the left atria. The blood will back up in the lungs as well, and there would be a pulmonary edema component coming up. So we will have to treat the congestive heart failure of this patient, and for management of this, you will have to use furosemide. I would say the main weapon that you have at the moment for management of pump failure would be furosemide, and along with that nitrates as well, because nitrates are not only reduce the chest pain of the patient by causing a coronary vasodilation, but because they would be causing a venodilation, they will reduce the preload as well as the afterload of the heart, and therefore the performance of the heart would be relatively better. The next patient that I'm describing before you is relatively worse off in a sense that the heart can burst. You see, the necrosis is so substantial that the heart is burst like a balloon. There was a ischemia, then there was a development of myocardial necrosis, and the necrosis is full thickness that it gave away. In this case, if there's a cardiac rupture, then person will develop cardiac tamponade, because when the heart will burst, the blood in the chamber of the heart will escape in the pericardial space, and the blood will accumulate in the pericardial space and will crush the heart ventricles from outside. His own blood is now in the pericardial space. It is crushing the heart from outside. So the term that is used to describe this in MCQs is called as electromechanical dissociation. The meaning of the word electromechanical dissociation here is that electrical activity in the heart is there. I mean, SA node, AV node is working, but the output of the heart is compromised. Why? Because there would be a cardiac tamponade that would be developing due to through and through rupture in the heart. But if there is a patient who is relatively lucky, then there may be a LV aneurysm developing. You see, in the previous case I had said there was a heart giving away, but now you can see that I have shown that there is a slight bulge of the left ventricle or left ventricular free wall. This bulge is again a recipe for disaster, because one, it can cause clot formation. These clots can go into the brain, and therefore there is a risk of development of embolic stroke. So for LV aneurysm, I need to use warfarin in the patient on a lifelong basis so that I can mitigate the chances of development of stroke in a patient. How would I know it is a LV aneurysm? Echocardiography will help me identify that there is a aneurysm developing in a patient, and apart from that, another finding in the ECG would also be present. That would be a persistent ST segment elevation. The reason for this persistent ST segment elevation in the patient would be that there's a structural damage which again causes this current to be persisting. The bottom line is, if after myocardial infarction treatment in a person, like you have got him out of the cath lab, but still the ST elevation is persisting, then you are wondering, I mean, what happened on angiography? I saw that the reperfusion had been achieved, but in spite of that, there is a ST elevation which is present, which tells you that there is a structural damage present in the heart of this patient. That would be a left ventricular aneurysm. And the next complication that I'm going to tell you is a late complication. You see, Dressler syndrome is a post-MI pericarditis. This post-MI pericarditis can cause a lot of, I would say, distress on the part of the patient, because he is again going to have chest pain, and he's going to think that he's having the MI again, episode of MI again, and he would need to be admitted in the hospital once again. So he's literally begging before you, doc, is it, am I so unlucky that I'm having an episode again? So I have a patient of MI who was discharged from my hospital about 3 to 6 weeks back. This particular person is taking low dose aspirin, he's taking statins, he's taking antihypertensive medicine, now is becoming regular with his diabetes medicine also, and after 3 to 6 weeks he is coming back to my hospital again with development of chest pain at rest, and he says I took some antacids etc., but there was no relief. Doctors were decided to come to the hospital, and when I did ECG in this patient, I found there was a ST elevation. But this ST elevation that is present would be not convex upwards, it would be concave upwards, because in pericarditis the ST elevation which is present is concave in upward direction, and because pericarditis would be present all around, I mean in majority of the leads, I can say, like if there are 12 leads, and almost out of 12 leads at least 10 to 11 leads would be having is a ST elevation. I mean, the only lead that would be having is a ST depression here would be lead number AVR, because AVR anyway reads the heart the other way around. So AVR will elevate. I mean, AVR is one lead where P wave and T wave are negative even on a normal person. So because P and T ST are negative in AVR because it reads the heart the other way around, even ST depression can be present instead of ST elevation. I mean, all the leads would be having ST elevation except lead number AVR. In MI, only few overlying leads would be having. Only few overlying leads would be having is presence of ST elevation, but in pericarditis, because it is 360 degree around the heart, ST elevation would be present in all the leads. Plus, you obviously will check out the biomarkers as well. And when you check out the value of biomarkers, you are not gonna get that gross, 50 times, 100 times elevation in a patient. In majority of cases, the tropi values can be normal, or they might be slightly elevated, but at least they would not have very gross elevations like the ones that you encounter in patients of myocardial infarction. And therefore, in these patients, you do not need to admit them. You will tell them that we'll put you on aspirin. Obviously, it can cause a bit of gastritis, so a bit of antacids and pantoprazole would be recommended, because of the fact that this is a autoimmune pericarditis. I mean, that's a question that is asked even in pathology, that what is the etiology behind Dressler syndrome. So your answer would be given as autoimmunity. And on reading the word autoimmunity, the first thought process of everybody is I should give steroids. We don't give steroids after MI because we want to reduce the chances of scar formation. We want to rather improve the strength of the scar formation. You see, whenever you are giving steroids, the chances of healing would be slowed. The chances of scar strength, the magnitude of scar strength would be relatively lesser. So I want to avoid steroids and will be using aspirin in the patient. Though, yeah, I mean, he says that in some cases aspirin may not cause complete relief of chest pain. You may have to use steroids, but in the exam, if he says what is the treatment for Dressler syndrome, then do not answer steroids. Then answer should be given as aspirin to be given to this patient. Nobody would ask you the dose, and they'll love to ask you regarding the etiology behind it in the same MCQ, because they know that the first thought process of anybody the moment you read autoimmunity would be that, well, it's gonna contribute. I mean, because autoimmunity is present, steroids are the first thing that come in our mind. So these are a couple of complications that would be seen after myocardial infarction. And then he can ask you what is the structural damage that can be seen, or what is the most common valvular lesion that can be seen after myocardial infarction. So the most common valvular lesion that can be seen after myocardial infarction is mitral regurgitation. The reason for this being damage to papillary muscles. You see, papillary muscles would be supporting caudate tendineae, which would be attached on the undersurface of the heart valves. And once you have damage to papillary muscles, then the mitral regurgitation manifestations can occur. And the worst case scenario can be that a person might even be having a septal myocardial infarction, which can result in a VSD. Now we know VSD is the commonest congenital heart disease per se, but VSD in an adult, that too after MI, could be a possibility that is seen after which could be seen after septal myocardial infarction. But the language of the question will say which is the most common valvular lesion, or what is the most common structural lesion that can be seen after MI. The answer is mitral regurgitation. Mitral regurgitation is also the commonest valvular lesion seen in pediatric rheumatic heart disease. In routine adult rheumatic heart disease, it's mitral stenosis, but in pediatric rheumatic heart disease, we have mitral regurgitation. If he says which is the commonest valvular lesion after infective endocarditis, it is again mitral regurgitation. That's because mitral valve in our body operates at the highest hemodynamic stress, so the chances of it getting involved would be relatively higher. And what I've explained to you today are some complications of myocardial infarction. I've told you definition of myocardial infarction, which is important. So yep guys, this is an important topic, not only from the perspective of the exam, but I can say just being a doctor, I mean, this is a common illness in our country, common medical emergency in our country, and if handled properly, I mean, the longevity of the patient would be dramatically increased. So thank you so much for hearing me out. Keep hammering, keep learning new things, and you will definitely do great in your careers.